Hi everyone. So the first topic for today is ADH, antidiuretic hormone, also known as vasopressin. So let's get started. ADH is synthesized in supraoptic nucleus of the hypothalamus. It is stored and secreted from posterior pituitary gland and also called as AVP, arginine vasopressin or argyropressin. We have osmoreceptors which detect increase in osmotic pressure and baroreceptors which can be found in aortic arch and carotid sinus which detect in decrease in BP, blood pressure. For functions of ADH, I listed up 5 of them here. First, as antidiuretic, it retains water in the body, which it acts on vasopressin receptor, which will increase insertion of water channel in distal convoluted tubule and also collecting duct, which will increase water permeability, increasing water reabsorption, hence concentrating the urine. It is also important for vasoconstriction, increase in platelet aggregation at high dose, increase in fatty acid production, and also stimulating contraction of uterine and gastrointestinal smooth muscle. There are two types of vasopressin receptors. We have V1 and V2 receptor. V1 receptor mainly on vascular smooth muscle as vasoconstrictor, for example talipressin and falipressin. Talipressin we use in esophageal varices bleeding for constriction of splanchnic circulation. V2 receptor can be found in renal and extrarenal. Renal as antidiuresis, for example vasopressin and desmopressin as mentioned earlier, and extrarenal increases release of von Willebrand and fatty acid, for example desmopressin. For physiology of ADH, when there is increase in plasma osmolality, this will increase ADH release, which will then increases water reabsorption, hence decreasing the plasma osmolality, which will then reduce ADH release. So the trigger factors for release of ADH, anything that causes body needs water. So increase in plasma osmolality, reduce in extracellular volume, angiotensin II, hypoglycemia, increased pain, and certain drugs. For the inhibitory factors, I just listed up 3 of them: alcohol, adrenatrolytic peptide, and also cortisol. One of the diseases of ADH is SIADH, which is syndrome of inappropriate ADH secretion, which can be caused by malignancy, mostly caused by small cell lung cancer, which is the most famous one. It can also be caused by pancreatic cancer. Any neurological disorders, stroke, SDH, SAH, infection, for example encephalitis, meningitis, any other infection, for example tuberculosis, pneumonia, and also certain drugs, for example thiazides, sulfonylurea, carbamazepine, and also omeprazole. So what are the features of SIADH? Usually it is asymptomatic until the sodium level is low enough, lower than 120 millimole per liter. Otherwise it can be as mild as feeling nausea or vomiting or headache, or moderate enough can cause muscle weakness or lethargy, or even can be cause confusion. When it is severe enough, it involves the GCS level. There can be seizure or altered consciousness. A bit tricky on how to diagnose SIADH. First and foremost, we have to exclude other abnormalities. We have to have normal adrenal function, normal thyroid function, normal renal function. Then the patient has to be euvolumic. There's no sign of fluid overload or dehydration. Then we check for the plasma sodium. It should be lower than 134 millimole per liter. Plasma osmolality is lower than 280 milliosmol per kilogram. And then high urine sodium more than 20 millimole per liter, and high urine osmolality more than 100 milliosmol per kilogram. So how to manage SIADH? For mild hyponatremia or chronic hyponatremia where the sodium level is more than 120 millimole per liter and there is no neurological deficit, first fluid restriction. Then we can use to second line democlocycline, which is semi-synthetic tetracycline antibiotic, which reduces response of collecting duct to ADH. And thirdly, we can use ADH receptor antagonist. But the first line fluid restriction is very important. So for severe acute symptomatic hyponatremia, where GCS less than 11, patient having seizure means any neurological deficit, sodium is less than 120 millimole per liter, life-threatening patient, so we treat using hypertonic 3% saline, but patient has to be monitored closely in ICU, for example, and then shouldn't correct the sodium level more than 10 millimole per liter within 24 hours or 0.5 millimole per liter per hour to avoid centropontine myelinolysis. We stop the treatment once the symptom abolish or we reach the sodium level 120 millimole per liter or more, and also the correction 80 millimole per liter is already achieved. So that is all for ADH. We'll move to another topic after this. Thank you.